right,
let's do this.
Let's do this.
So this is going to be our first of the series of talking about functional movement between the three of us. So I'm Jim Nugent.
I'm Steve Powers.
I'm Miguel Bunker.
And we are at River Forest Health and Wellness. So today what we thought we would do is kind of sit down and talk about like what are we looking for in a squat when it comes to functional movement, and what do we see with some of our patients that cause a breakdown, maybe some knee injuries or some back injuries from squatting. So yeah, that's what we're going to kind of talk about and go through today on this this little video cast. So you want to start? So what's the first thing you're looking for, buddy?
The first thing I have them do is I just like, hey, get comfortable, however you feel is what feels good for you, and I say, show me the squat. And I mean, for me, a squat is it's a full body exercise. You know, from head to toe. How are you stabilizing? How are you controlling your body against gravity? If I had to narrow it down, I'd say the biggest things I look for in a squat are like, can you keep your spine neutral? Like, we don't want a whole lot of excessive like lumbar flexion or extension. I'd say that's the first thing I look for.
Okay.
Yeah, keep it relatively simple.
And to add on to that, like the things that I start to look for, like, getting up and sitting down from a chair. I know it seems like it's a very basic movement, but this is sort of a foundational. We do this all day long. Right? So like everybody's doing this, right? So sometimes a patient comes in and they're sitting down, and as soon as they like stand up, that's the first bit. Are they struggling? To get off the chair? Are they leaning to like one side? Are they putting their hands on their legs and using their hands and not their core, their leg muscles to get themselves up?
Right? To push themselves.
Exactly, right. So that's sort of the foundation. Like, are you really using the muscles that you're supposed to use to lift yourself up? Because you aren't, then we have to start addressing like more of the foundation, right? Starting from here, being able to create intra-abdominal pressure to be able to like lift you up. So that's sort of like the main point that I look at. And then we can start breaking down like, different mechanics of, are we bending at the ankle? Are how far forward are our knees traveling? Are we hinging at the hips? Am I flexing the spine too much? We get into those mechanics later, but that initial movement of just getting up from a chair, like that's the very first step.
Yeah, I mean that's every patient from a 6-year-old to a 90-year-old that we can be assessing. We're all getting up out of chairs all day long.
Right.
There's out of the car, out of the chairs. So
yeah.
No, I mean I like that. That's a really nice way that I think a lot of us we don't, without even having them do a squat. You can just watching them sit and stand from a chair. We're going to get a ton of information.
Totally.
Exactly. Yeah. You walk in and we're already assessing.
Exactly.
Yeah.
Exactly. One of the things that I look at that we don't necessarily look at all the time, and this is like you were kind of talking about this in like not directly, but how much kyphosis, or all of us are sitting like this, and how hard it is to actually squat if you can't be in a more upright, more neutral position. And I think that as chiropractors, one of the things that we like to do is address the back, right? Mm-hmm. But which is great, but we can be showing our patients how to mobilize that kyphosis from sitting at the computer all day long, and just by doing that would help them be able to get a little deeper into the squat or take some pressure off their low back with the squats. And I think that's one of those things that are we're always looking at, can they hip hinge? Yeah. Is there enough motion in their foot? But I think one of the things that sometimes, at least I forget about, and I have to kind of always go back to, is like, do they have enough mobility in their upper back to actually get down into a squat, right? And that brings into the kind of the DNS stuff that you were talking about with expanding and trying to get the abdomen to create good pressure.
And I think one thing our bodies are great at doing is adapting to the environment we put them in, or adapting to how we modify ourselves around the world. Like one thing you mentioned, like getting out of a chair, with a lot of people, like they lean forward and then they push themselves up. A lot of what I'll see patients doing squat that aren't used to doing them, they start bending at the back first, and like they lack a lot of hip mobility. Right. They can't support their body weight over their pelvic girdle.
Exactly.
Yeah, like hip mobility I think is just huge. And we're sitting in chairs like for all day, or at work, or sitting in cars or airplanes, and we just have a tendency to sit like this, and now we're sitting.
We're just as guilty. We do it
exactly.
all the time.
Like it's comfortable. It feels good.
Trying to get comfy, yeah.
But what this ends up doing is that now it creates compression on the glute maximus muscle. This huge meaty muscle that we have here that's perfect for extending the hip. So we're sitting on it all day long, and now we're compressing it. We're reducing the amount of blood that those muscles get, right? We're also reducing the amount of like nerve conduction to that muscle. So with that, we're gonna get a muscle that's normally very big and strong to start to atrophy, right? So we get that chair butt syndrome, right? And so then we're supposed to lift things up, say like a bag of groceries or laundry basket or a small child, and we're supposed to use this muscle that we don't. So now we're forcing to, use our back muscles or just use muscles that are not really meant to lift that heavy weight.
Body adapts.
Yeah.
Yeah.
So I guess like the three big things that we always like to look at is, can the person hip hinge, right? I mean, that's always the first one, right? And again, going back to the foot, is like, can they is there enough mobility in the ankle to be able to go a little further down? And we were all kind of talking yesterday about putting something underneath our heels to make sure that it's not cheating if the person doesn't have that much motion in their ankle. Like, that's okay to do for now, and then try to staircase them down after that. I feel like we kind of blast all these tools that we use that can help us get a better form, because like you were saying, we got to respect our anatomies, right?
Yeah.
I mean, if your ankle is not going to dorsiflex well, but you still want to squat, let's give people some options to be able to do this more effectively.
And even like respecting anatomies, but just respecting like adaptive anatomies. Like when you're treating athletes, like you're gonna have different elastic recoil in certain tendons than others. A sprinter, you're probably not gonna have a whole lot of dorsiflexion because they rely on that elastic recoil to help propel them forward faster. Versus a dancer, ballet or something, you might be able to put their toe to their shin.
Right.
And you just have to respect what each athlete's demands are.
Yeah, I mean, both of them have strong calves, right? I mean, again, like two different functions, but very, very strong calves.
Right.
And some person might have a much longer femur, some person might have a shorter femur. So, the myth of your knees cannot go over your feet, like, we gotta be able to go a little bit more granular, right? And see like each individual person, and how they move. Like, obviously, this is not how we would normally sit down, but it's not a bad motion in and of itself. It's just we need to make sure that the tissues, the tendons, the bones, ligaments, everything has the resiliency to handle a movement like that, right? So we have to look at each individual person, like how they're moving relative to the motion that they want to do, and that's where we say like, hey, like maybe you might need to sit a little bit further back, but your squat is great, like even if your knees go a little bit past your feet, like that is ideal for your body type.
Your anatomy.
Yeah,
right?
exactly.
Respect the anatomy.
Respect the anatomy.
Get a tattoo of that somewhere.
We should, right? On our forearms, right?
I know exactly. But I would say, if someone is lacking like ankle dorsiflexion, right? We have exercises and movements that we can do. Like we can repeatedly bring the ankle into dorsiflexion. Dorsiflexion is, when we lift the ankle this way. So we have exercises to do that, exercises to strengthen some of these muscles here, just to create a little bit more mobility there. And a small change here might mean a huge change in the global pattern, right? So we got exercises for that. We got exercises to loosen up the hip, to be able to practice strengthening and activating the glute max muscle so we can lift and we're not overusing our lumbar spine. And then, our favorite one is, creating intra-abdominal pressure. Like that's the foundation of everything.
Yeah. Can they breathe? Because we can't forget that your brain will prioritize your respiration over any other physical activity you can do.
Right.
If you aren't breathing properly, you're not going to move properly.
Yeah.
Well, this was cool.
Yeah.
Love it.
So expect this more from us. We're going to sit down and just chat about stuff. So if you're a patient of ours who is looking to have us break down your squat, let us know. If you're a new patient and you're like, hey, I'm getting pain with squatting, knee pain, hip pain, back pain, whatever it is, come on in. Let's see if we can help you change the mechanics and respect your anatomy in your squat.